Good morning or good afternoon. This is Russell Hendrickson with PDS. Thank you for joining us for today's Patient Risk Acuity Analytics webinar. Joining me today is Becky Cook. What we're going to do is talk through and show you some of the technology we're using and try to address how to use analytics to better improve patient risk acuity management and how to maximize revenue. Today, the analytics tools have gotten very powerful. It's very easy to look across a population, to publish data, to begin to understand, at a touch of a button, I can quickly highlight where are my Blue Cross Blue Shield patients and where are my diabetics and which offices might they being seen in, or how many of those patients do I have. At the same time, if I want to go to a more slice and dice type visualization, I can quickly assign out the projected revenue of these chronic condition patients. I can quickly filter, look at a particular location, or look at where we potentially have gaps in our process, whether they're quality gaps or clinical gaps, and begin to understand, where there are opportunities to improve performance. And that really is the topic for today's webinar, which is how do we identify gaps using analytics, specifically related to, risk-adjusted contracts. And then how do we use this identification of gaps to further break down, are they reporting gaps where we're providing the right quality of care, but we're not getting paid on it? Or are there clinical gaps where potentially we're missing in treating patients, and so there's an opportunity to improve quality of care, which also can result in a stronger bottom line. And so through the use of analytics, what we're going to do is talk about identifying gaps and then closing gaps, and where are there different opportunities to improve and perform better.
So for those of you who are familiar with me, I'm a former CFO, and I tend to focus on the aspects of physician practices and hospital practices that are financially driven. How do we increase revenues? How do we help the organization perform better? And this year's challenges are really working with organizations on adapting to and implementing the changes needed for MACRA as well as value-based reimbursement. We talked for several years prior that these were coming down the turnpike, and definitely we are getting implemented on these. So I wanted to share with you some of the things that organizations are doing to use intelligent data and analytics to aid in their decision-making, how we're using dashboards and visualizations to engage our physicians as well as our staff in these quality improvement initiatives. So let's hear from our audience today on your participation in some of these contracts. There's a lot of variation around the country. Some of you have already started participating in these shared savings or incentive contracts, but we'd like to see our participants today, how far and what types of contracts that you've got. So let's look and see what this audience has. So we have Medicare Advantage. We have the bulk of the answers in the yes, all of the above, Medicare Advantage, Medicaid, and commercial insurance. And then we still have 20%, 18% of our audience that's not participating. There are lots of challenges with participating in these contracts, but I think that using data and using analytics is helping us overcome some of those barriers to get more people participating, more organizations participating. So MACRA is definitely a data-heavy initiative that Medicare is implementing. I would tell you that this might go away, but I don't think it's going to, because the concepts of monitoring quality, using our EMRs to improve our clinical practices, and reducing cost are becoming rather universal. So it's not necessarily the government programs that are driving these anymore. In many cases, it's the physicians themselves who understand that this is the way they want to practice medicine. The biggest component that is changing lives for people is the cost component. Cost, as it's implemented and used in MACRA, is the cost of medical services. So it's the medical service ratios divided by the risk score. We add up all of the cost of patient care and we divide it by the risk score or the acuity level of our patient population to calculate adjusted cost. The insurance companies have been doing this for years and haven't necessarily told us about it. The illustration below, the little graph that's divided into quadrants, is typical of how the insurance companies are looking at organizations. They are looking at the adjusted cost and graphing the different organizations in a grid like this. And what they are doing is making decisions on fee schedule implementations and new contracts based on where you fall in this quadrant. If you're in the upper right, you are what's called a high performer. You have lower costs and higher quality at the same time. If you're in the lower left quadrant, you have higher costs and lower quality, and you're going to be the last to see some of the benefits of incentive plans and rewards in your fee schedules. So the worst thing that can happen is you get to the end of a performance year and you find out that you're just over the line into that lower quadrant or even the upper left or lower right. You want to be positioning yourself in that upper right quadrant. So how do we manage to get there? We need a risk profile. Russ, tell me, I know that the risk profiles are based on diagnosis codes, but what else goes into developing the risk profile?
So, here at PDS, I like to think of this slide as sort of levels of usage of analytics because, we can start looking at diagnosis codes or build claims data, which is typically the first place to start. We can, get more complex looking at our populations or start to score patients. So we're going to show you these through the webinar today using HCC risk scores. We can then start to join and blend in payer data, but ultimately what we're really looking for is performance management, and this is how we measure it here at PDS. So this slide, I think, really represents some of what we're going to talk through today is how do we move and use different levels of analytical data as we try to manage our organization to these higher levels of performance management. With that, we have another survey I'm going to launch up on the screen here.
Thanks, Russ. So looking at the role that analytics is playing in your current incentive and shared savings contracts, how much do you use analytics in negotiating and manage your plans? We have 17% who say that they're not using, and then another 22% that are in the lower quadrant, 0 to 25%. Somewhat. So we definitely have a skewed response here to the lower side of not using it or using it a little bit or somewhat. We have a couple of high performers who are in the moderate and highly significant use of analytics. So this is probably typical of what we're seeing right now. People are still approaching analytics and trying to understand how to make it usable to run their practices.
Great. So let's break that down a little further. Let's talk about the different ways that we might approach building out analytics around risk acuity modeling, and what are some of the data sources that are pretty typical. Here at PDS, one of the first places we start is with the billing data, with the diagnosis data. Obviously, this is the data that the insurance companies are getting from the organizations, so it's the first place they're looking. We then stage in and model in the risk scores. You'll see that coming up in the webinar. And then when we start to build and move to the higher level of analytics around risk scoring, we want to be able to blend in the other factors that contribute to our success, be it patient satisfaction data as a measurement of how are we performing, scheduling and looking at patient access metrics, or when we actually start now to blend in the clinical data to make sure that not only are we checking, for example, A1Cs, but that our patients are being managed appropriately in their levels. Through this stage data that we can then model it and transform it to make it intelligent data, I'd like to say, and then from that we can start to build out analytics and dashboards, and you'll see some of the examples of the way we're helping organizations do that coming up here. From a usage side, I always like to think in terms of answers. What are the questions that we need to answer, and where are those levels of data? So if we think back to that other screen I just had, we may want to start with what we're billing, but then we want to start to look and understand how does that roll into visiting patients at the encounter level, and then ultimately who are our patients? What are their chronic conditions? How do we look at patients and compare year-to-year risk scores? This is where we can start to identify who should have been in, who needs to be seen and hasn't been seen, or where there are coding gaps. And ultimately then when we talk about contracting, which Becky's going to do coming up, we talk about being able to analyze patient panels, profiles, and look at shared incentive agreements where there's revenue tied to expense. From an analytics side, it's critical that we have the data staged. So you can almost look at this as an architecture type diagram within a data warehouse. We could start to look and say we need to be able to slice and dice and drill through different levels of data depending upon what we're managing and what questions we need to answer.
It's interesting there that it's not necessarily hierarchical every time. You don't necessarily need to go through patient year score to get back down to want to understand what was the diagnosis code that precipitated the risk score.
And that's a great point, Becky, and I'm glad you drew that out, that you may not just drill down level by level. You may be at one level and need to go right to another level of data to answer the questions based on what performance gap you're working on.
So I remember that we had about 80% of our audience that's using data in their decision-making processes, so we'd like to hear from you. What type of data are you managing to access? What's the valuable data that you're going after in your organization for these contracts? We have billing data, your EMR data, payer data, scheduling data, none of the above. Okay, we expect billing data to be included for most people. EMR data is a little more difficult to get, but equally as valuable, and payer data is there. Where we see a gap is with scheduling data. I think that that's a very valuable source of information as we work with patients, and then it looks like everyone is getting at least some of the data that they want. So Russ, let's go ahead and talk about how we start to use some of the data that we have now at our fingertips. The first place that I start looking at these contracts is understanding my patient population. In the past, I've had to do things like build graphs based on the demographics of my group, looking at the number of patients that I have in an HCC category, looking at the number of physicians and their patient risk scores for their population, looking at the size of the population based on the number of visits because I didn't have the number of patients. Unfortunately, this doesn't really help me understand the linkages between these. So they're interesting, but they don't really help much in my decision-making process. What I really wanted was this type of analysis tool. So this is a bubble graph. It's divided into quadrants, and this gives me the ability to put multiple pieces of data into this quadrant at the same time. So this one actually represents the HCC patient count along the x-axis, the horizontal axis, and it has the average risk score along the y-axis or the vertical axis. The size of the dot represents the number of patients, and you can see the physicians represented along the side. So if Russ pauses on one of these buttons, for instance, you can see very clearly that the details will pop out as to who is the physician, what is the HCC patient count, and what is the risk score. So I can start to use this data now intelligently to look at specific cohorts and to understand which physician has the most patients in a particular disease category, who is working well with risk scores. So unfortunately, what I see are the physicians who are working well with risk scores that Russ has highlighted are not the people who have the most patients. So I'm kind of upside down on this contract. I can also start to look at this by location to see if I've got physicians in a particular location who are not working well and try to determine some of the root causes of my lack of specificity in the data.
Excellent, Becky. As we pointed out, I can highlight, click, filter because we're using visualization technology with what they call interactive panels. For those of you who are used to looking at data or want to get a little more granular, the same data set behind in the analytics, we have the same sort of slice and dice filter capability. I can point and click and drag and drop. We can filter on a particular payer or look within the payer, start to see how many patients that exist. And, if you remember back to that levels page that we were talking about, if I just want to see this subset of patients here, it's literally slice and dice, point and click, and drill down. And now we're down at the patient level, looking at patients and all of their individual patient level risk scores across different time periods. I could continue to slice and dice right through the data at this point. So whether we're using visualization technology or using sort of traditional analytics, the key here is if that data has been leveled up, from a business perspective, I can answer the questions and quickly start to look at what I need to understand where we can improve.
So, Russ, I may have jumped a step ahead because when I said if we have the data, we can start to create profiles of our patient population. But one of the first things I want to do is to make sure that I've got accurate data. And the best way to do that, I think, is to do the Medicare annual wellness visits as well as to bring other patients in with Medicare Advantage, commercial insurance plans, and to gather the data that we need during those annual assessment visits. They're not necessarily physicals, they're more looking at what is the patient's level of risk, what chronic conditions do they have, what care do they need, putting together a care plan. But it's the best place I know of to make sure that our data is accurate. So when we start to organize those visits, we can do it in lots of different ways. I think the one thing to remember, at least for your Medicare patients, is this is an additional source of revenue for you. See, I told you I'm a finance person, and that's one of the things I look for. Right now, nationally, only about 15% of Medicare patients are getting their annual wellness visits. At the reimbursement rate and a population of around 8,000 patients, which is not unusual for a small practice, that's about $140,000. The insurance companies, the Medicare Advantage plans, the MSSP plans are really pushing to get to around 85% of annual wellness visits. And you can see there the estimate, the increase in revenues that would go along with that. So not only do you earn the incentives for hitting that target, but you earn the additional money from just doing the visits. You also have the opportunity to review the specificity of your diagnosis codes to make sure your demographics are correct and really to document all of the opportunities to provide care for your patients to improve their health. So let's look at a way we might organize these cohorts. I think it makes a lot of sense to organize your Medicare wellness visits by chronic condition, by age groups, by location, lots of different ways that you can put these groups together. Because you have staff doing a significant portion of the wellness visits, you can schedule your practice to start early in the morning, late in the afternoon, and to do a lot of the work in group settings. I know that there are practices who basically have coffee parties, coffee clutches, that type of thing to make sure that they get their Medicare wellness visits and to entice their patients in. Medicare itself is actually offering patient incentives in 2018 to bring patients in. I believe it's a $25 stipend if they will go in and get their annual wellness visits. So even the insurers are recognizing the significant value that can come out of these annual visits in terms of documenting data and understanding our population. So what do we do with all this data?
Yeah, so as you can see on the screen here, very similar to the analytics I was just showing, if we can report on that, which certainly we can through our staging, you'll notice here we're looking at patients. I can filter, who is missed or is overdue for a wellness visit. When was the last time they were in? We can then, by joining scheduling data to this data set, we can automatically filter out and say, well, we don't want to schedule patients that are scheduled to come back in, so we don't even need to focus, identifying gaps. We can see who came in, when they last came in. We can even filter and say, well, if we're going to start making phone calls to bring patients back in, let's look at the patients that have a moderate or a high level of risk versus those at a low level of risk, kind of prioritizing and staging appropriately using the data. So, the same technology, whether we build a visualization or we focus just using the analytics, makes it very easy to identify where there are opportunities to improve quality of care.
So now that I know which patients are going to benefit most from care management, where I need to focus my efforts, one of the other areas that has opened up for us as opportunities in 2017 is implementing complex chronic care management. Medicare has made it easier to capture this information and to engage our patients. All they want is 2 or more chronic conditions, and if you noticed on the dashboard, it looks like PDS has flagged those patients who have multiple chronic conditions for us so we can identify them. We now only need verbal agreement from the patients to participate, which our care coordinators are capturing the first time they call a patient, or specifically calling to find out if the patient is interested in participating. This makes it much easier for the care management staff to assign patients, to make sure that they are prioritizing patients in the way that they need to look at them. So our care coordinators are both scheduling patients for preventive care as well as following patients with chronic care, and they really need good data in order to do that. The complex care management is really needing a projection of HCC growth, the acuity increase, and which patients are priority, because I only have so many care coordinators. A good data solution is also going to let you do financial projections on what is my opportunity from applying care coordination for these patients. So this is an analysis looking at the physician level, how many patients they have placed with our care coordinators, what is the acuity level of those patients, what has happened to their patient population and acuity over the last 2 years, how might their population change, and in the increase in minutes per patient per month and in the increase in the number of eligible patients. We can actually change those parameters in this to develop our financial projections for this year or for next year, for instance. We also have physicians flagged as opportunities based on the number of patients or their average minutes, whether they have an opportunity, with the red and yellow indicators in the far right-hand column.
So Becky, I've talked to a number of organizations about this, and in most cases I hear either we tried it and we couldn't make it work, we couldn't make it cost effective. You know, what do you see as the biggest barriers to organizations right now? What are you hearing as to, you know, if organizations are actually taking advantage of the decreased requirements to take advantage of this program?
It's actually the data management, locating the patients, understanding their chronic conditions, and making sure that we can capture the data. So once the care coordinator has actually worked with the patient, making sure that they have a place that they can record that information and getting it to the billing department to bill for it. So turning this revenue opportunity worksheet, for instance, into a scheduling worksheet and into a visit worksheet for the care coordinator so that they have someplace to document this information and get it back to the biller, lets you then pull those statistics into next month's report so that you know what was done last month. Very easy to do. You'll notice that the 2 indicators on the far right-hand side, these are big barriers. Making sure that patients are enrolled in care coordination and engaging the physician is a barrier. One of the big opportunities is looking at the amount of time that's being spent with patients. The codes from Medicare have a big gap in them. There's a code for if you're spending 20 minutes a month, and the next code says you have to spend 60 minutes a month with the patient. So if you're spending somewhere between 20 and 59 minutes, you're spending time with patients that's not billable. And Medicare says you have to continue providing that level of care. So understanding what's being billed and how much time is being spent with the patients is really important to help you design your care management program.
Excellent. Thank you. The next section of our agenda today is to talk about, you know, managing the care measures for risk-based contracts. And this is, I think, the area that most people, when they think about using risk scoring, this is the area that usually comes to mind. Becky, can I ask you to speak to that as well?
Sure. In the analytics that I'm seeing, or the measures that I'm seeing in current contracts, there's a mixture of both preventive care measures as well as care being provided for at-risk patients. So we're using analytics to identify the patients in the population who need preventive care, as well as to identify patients who need periodic care during the year. So the patients, for instance, who are on medication, ACE, ARBs, diuretics that need quarterly labs or twice yearly labs. Making sure that we have patients who are assigned a high risk level are assigned to a care coordinator and that we're engaging those patients. So we're spending a lot of time with our analytics solution and with our databases to make sure that we can properly identify those patients. One of the ways that, let's see, do you happen to have a graph or a spreadsheet there?
Yeah, I was going to say actually I was going to show a little bit of how we might do that. So I thought I'd start first with kind of the analytic, to echo what you said, Becky, here. So here we are looking at the analytics. This has been staged data. It's at the patient level. We're looking at the provider. We're looking across their HCCs. So you can see this patient here has multiple HCCs. And then we can start to look very quickly. And what you're seeing here is this suspect or decrease. And what we're doing is we're comparing scores year over year to look for those gaps. So if we know a patient has been in and they have multiple chronic conditions or a single chronic condition, we can then quickly identify that this patient hasn't been seen. They have not been seen, or if they were seen, there potentially is a coding issue. So what we term at PDS here in our analytics is current year suspect, or you saw before I had on the screen that coefficient decrease. What it's showing is there's a gap in scoring that the patient either hasn't been treated appropriately or we haven't coded it appropriately. And we can continue to slice and dice right through the data, whether we want to look at it by HCC category or we even want to break it down and start to look at it by payer to see what and where potentially are we patients that are being either missed or there's coding issues, and both will have an impact on our reimbursement.
Now I can see lots of opportunities for focusing our efforts, making sure that we're getting the care to the most important patients, ranking them, working by payer, lots of opportunities that we haven't had before.
The same data, if we build it into a visualization, might look something like this. This is just one representation. So we talked about those gaps, right? So very quickly, you'll see here we have orange, which is the current year, where there potentially are gaps, and the yellow, which is the prior year. And knowing that you can still correct and re-report on prior year, there's opportunities in both the current year reporting and the prior year reporting. But I can very quickly click on a circle and identify now which physicians have the most gaps, what is the projected revenue tied, and even what are the HCCs that are either being missed or the patients with the highest chronic conditions where they might sit. So it makes it very easy to slice and dice through the data and or communicate, where there are opportunities. And this could be done by location, could be done by payer, and as we'll talk about physicians and reporting to physicians where their gaps are, which is coming up, making it very easy to understand at a touch of a click where there are other opportunities and what's the cost if we don't manage those opportunities appropriately.
Okay, so one of the things that I see that's of interest to me is that little pie graph down below that shows me how many patients I have in the high-risk category, moderate risk, and low-risk category, so that I can very quickly start to evaluate what's the status of my organization in terms of being able to meet these metrics. One of the things I guess I'd like to do is to break down some of these metrics one by one and see where we actually are and how we can make sure that we're going to hit the metrics that we need by year end. So here we have some of the metrics that have been provided by our payer contracts. And what I want to be able to do is to show our board members and our physicians very quickly for the group, where are we with hitting these metrics? As they start to understand the value of hitting the quality metrics as well as the cost and risk measures that are needed for these contracts, they start to pay a lot more attention to these. And one of the things that is useful is to be able to convert this into a graphic format, and you can see the little arrows that shows where we are, and the colors represent where we have to be in order to hit those metrics. with the teal color, the turquoise color being getting the maximum payout, and green going down to hitting the 75% level, etc. So one of the things that I do with this particular graph is to convert it to actual numbers of patients. Oftentimes the physicians have trouble interpreting. If we have to go from 75% to 80%, that doesn't really mean anything to me because I'm used to seeing patients one by one. So you'll see out there in the far column that we've actually converted this to the number of patients for the practice so that they can start to understand how easy it is for them to actually hit these metrics.
We have one other dashboard, this one bringing in data from the payers. Becky, do you want to walk everybody through this one as well, please?
Oh, sure. So one of the things that drives physicians crazy is having to look at some of the spreadsheets that the payers send out. They tend to be lengthy, they're payer by payer, and the first thing they always ask is, well, how am I doing on one contract compared to another? What we've done with this representation, this dashboard, is to try and make it easy for the physicians to go across and say, how are my diabetic patients in total doing, and then breaking it down instantly by contract for them so they can rapidly see, for instance, under clinical quality metrics, my diabetic monitoring, which is just getting a hemoglobin A1C annually. I have green, red, green, and in total green, but I'm going to have trouble with that middle contract, that Cigna contract. So it, again, helps them understand, am I treating my patients consistently regardless of their health plan? We can put patients in here who are private pay and could even treat them as a group. So we have lots of opportunities for the physicians to start to understand their data better.
Last year, we want to talk about analyzing value-based contracts and looking at shared savings plans, and how can we present and use some of the same information that we've just shown through the analytics to roll up, whether it's to negotiate or present internally or look for those performance opportunities. So, Becky, do you want to, at a high level, share what you put together here for us?
Sure. So one of the things that I want every month is I want to see by contract and for all of my contracts, where do I stand? And the easiest way for me to understand this is to have some trend data, to have some comparison to targets, to understand where I have good results and where I'm lacking with those results. So there are a couple different ways I can look at it. I've got my quick answers down the left side of the middle rows, the middle data set there. And those are my targets based on my contracts. And I can quickly scan and see I have some work to do before year end. My office visit gives me a good idea of volume, but it's also one of my indicators that I want to make sure that my annual wellness visits are done. And this says office visits, but it could just as easily be my annual wellness visits. Interestingly, more of the insurers are asking for outcome data. So is my hypertension controlled? You can submit CPT-2 codes for this, but I also find that like the Blue Cross Blue Shield plans are asking for the specific blood pressure measures that have to come out of the EMR. So I need to know how are we doing with these particular measures being reported out of the EMR. It's difficult to get that data. So I want to make sure that I'm gathering that data early and monitoring what's happening. I also represent, again, the number of patients where we have opportunities and we need to manage those patients. It helps, again, to mentally understand how am I going to see all these patients and where do I need to focus my efforts for the rest of the year. So dashboards to monitor performance. What I also want to do, though, is once I have this, I want to see what the financial results are. And I find that this actually can be used to engage physicians. Number one, I want to use this information to make sure that we are dealing with our data anomalies, that we've got our diagnosis codes that we collected during our visits specific enough to accurately reflect the chronic conditions. From there, I can add financial information based on what would be the payment to the contract, not necessarily to the physician, but for the contract, of making sure that I have this corrected data. And you can see here from, for instance, the first line, the first patient there in 2015 had a diabetes with complication, HCC, diagnosis code. And what we see is that in 2016, that patient has not yet had a diagnosis code recorded. So we've captured their demographics payment, which is the $990, but we haven't captured the portion that is due to having a chronic condition with complications, and that's $3,300. When we start explaining the use of this data to physicians in terms that they can understand, this is what it's going to mean to the contract, and subsequently this is what it's going to mean to your distribution, we get a lot better cooperation and enthusiasm about having to do the additional coding or to capture some additional data. These physicians tend to be very quality driven in the first place. They want to provide quality care for their patients. And so just adding this data can encourage them to participate at a higher level and sooner in the year so that not everything's trying to get done the last few minutes of the year.
Excellent. So, let's dig in now to physician level dashboards and how do we compile a lot of the different data points and yet make it easy for physicians to understand. And, I sort of put this in communicating with physicians yesterday. Obviously, you're still doing this today. There's a need to continue to monitor productivity and look at scheduling volumes, coding curves, bring in benchmarks, and ensure that you're hitting patient satisfaction goals. Most organizations have physician-level dashboards that are showing and blending these types of data points. When we start to go further into Becky's point, how do we communicate with physicians? Certainly showing them the financial impact of the organization, but when we start to break down, what does this mean for you? How many patients do you need to see? The data has to be graphical. It really does need to highlight what is left, where are the exceptions, and it needs to be very simple to digest. What we don't want is physicians poring over report after report after report. Dashboards visualization makes it very easy to do some of these things. This is a sample dashboard that we put together to look at some of these key indicators, but you'll see right across the top of this screen here in the darker blue, what is left to be completed here. So here we are in September. If you look at the report, you can see over on the right side, we've got about 80% to complete for the year. We know there are at least 20 patients based on 2016 scores, and we actually anticipate there's another 7. So there's 27 approximately patients that need to be completed by year end. And so this is what we're trying to do, is to make it very easy for the physician to break down, what do I have to do, when do I have to do it by. The same data here, we can then visualize out into a physician dashboard. So very similar to the organization dashboard, a dashboard could be visually interactive for a physician, could break down again. Here we have our gap and suspect buttons. Just simply clicking on this, you can see there are 13 patients that fall into that category. We can look at the levels of patients. We can look at patients by location or by office. So, through your analytics, the same data, whether you want to use something that's emailed, something that's on the web, or a full visual interactive with the slice and dice and drill to get down to the patient lists. Right? The technology makes it very easy, provided you've got all the data points scored. So it's very easy to visualize what you're seeing here. Becky, did you have anything to add on this?
I think this looks great, Russell. I think one of the challenges for me has been that working with patient risk acuity is a new challenge. It's one of the things that we are being asked to do that I didn't have any background with in the past. And so having these types of visual dashboards to show me what's happening is really important. It makes it a lot easier for me to grasp the concepts and to understand what I need to do to move those bars up and down and to get the pie graph looking the way I want. It's very easy to focus my efforts. I want to make sure that we're taking care of patients, but also that we're earning all of the revenues and incentives for the physicians, because that's what they ask me to do.
Yeah, I mean, it really comes down to making sure we're collecting, every dollar that's out there, sort of in traditional revenue cycle, and then obviously managing those incentives and looking at the gaps to ensure that we're maximizing the incentives especially with most payers looking at increases in incentives are through quality and quality metrics rather than just productivity-based like they've been traditionally. As a company, we really focus on helping organizations get answers, visualize data, and distribute information. And so getting answers is the kinds of questions that we're addressing today. How many patients need to be seen? How many patients have decreases in risk scores? What's the impact financially if we don't treat all our diabetics appropriately? Which physicians might need additional care resources to ensure they're effectively managing their current population of patients. And those are really the kinds of answers that we've discussed in this workshop today, but really flows through any type of analytical questions that you might be struggling to get data to. And then, of course, visualizing into dashboards, and you've seen a number of different ways we did that with today's topic, but we certainly were more expansive than just the topic addressed here today as a company. And then, of course, distributing information. We here at PDS, we are experts in understanding healthcare data and staging and modeling data, or turning, if you will, raw data into intelligent data that can answer questions, blending data from different data sources, again, like you saw today, and then, of course, designing dashboards and visualizations, and, of course, your overall strategy for reporting and analytics. So with that, Becky, thank you so much for the insightful information you shared and being part of the presentation today. And with that, this concludes our presentation. Again, thank you for attending. Have a wonderful day.